My topic is on malignant hyperthermia. It was first recognized in 1960s. It is a rare myopathic disorder characterized by acute hypermetabolic state within the skeletal muscle tissues following the injection of. So actually, it is a which is potent inhalationals and potent trigger is inhalationals or succinylcholine, resulting in increased carbon dioxide production and oxygen consumption, presenting with a fever, tachypnea, tachycardia, acidosis, hyperkalemia, and myoglobinuria, raised CPK cyanosis, and it may result in death. The incidence is most common in children and adolescent age groups. Etiology can be it is an autosomal dominant with a variable penetrance. Multiple mutations can be seen. Most common is a skeletal RYR, ryanodine receptor channel, type 1 is mostly involved. Other than that, L-type calcium channels, dihydropyridine calcium channels, some polygenic mutations also involved. Pathophysiology, this inherited disorder of calcium handling in the sarcoplasmic reticulum of skeletal muscle. Genetic defect is found only in the gene encoding the intracellular ryanodine receptors responsible for the calcium release in the skeletal muscle cells. So what happens is in response to halogenated volatiles or depolarizing muscle relaxants like succinylcholine, uncontrolled release of intracellular calcium ions occurs, which leads to muscle rigidity and hypermetabolic state. And this results in a buildup of breakdown products of skeletal muscles. I have drawn a flow chart, sir. So the trigger, once the trigger agents come in, action potential propagation along the skeletal muscle surface occurs, and the transduced by the voltage sensors. Then occurs a conformational change in the voltage sensors, which is transmitted to the hypersensitive calcium channels and in the ryanodine receptors. There occurs uncontrolled release of calcium into the myoplasm, which triggers increase in activity of pump and exchanges to correct the calcium levels, which causes a rise in ATP need and thus heat production, presenting with the hyperthermia. On the other side, there will be persistent increase in the intracellular calcium, which will raise the BMR and increase the carbon dioxide production and result in hypercapnia. And also there will be abnormal Cerca pumps, which have the inability to reduce the unbound intracellular calcium levels and result in rigidity. Altogether, present as a malignant hyperthermia. There are so many risk factors involved. Among them, the neuromuscular diseases like Duchenne muscular dystrophy, Becker muscular dystrophies, osteogenesis imperfecta, central core diseases, etc. See, other than that, the ortho procedures and ophthal surgery procedures, especially in the pediatric cases, then head and neck procedures, and the body habitus having the Marfanoid features should also raise suspicion for the malignant hyperthermia. Features, use of succinylcholine or volatiles may be followed by a presentation of hypermetabolism with a raised EtCO2, tachypnea, cyanosis, and unexpected metabolic acidosis. And there will be hyperthermia, where fever, sweating, and core temperature may rise up to 43 degrees Celsius, and rise in the sympathetic activity, presenting with a tachycardia, tachyarrhythmias, and hypertension. And the muscle damage, rigidity can be seen, like either a generalized rigidity or a muscular spasm presenting and it is expanding. Raised in the creatine kinase levels, myoglobinurias, polar colored urine with hyperkalemia and hyperphosphatemia can also present. In immediate changes, what we can see is a hypermetabolic state or abnormal muscle rigidity under anesthesia, like a messenger spasm, rapid rise in the EtCO2 values. If EtCO2 monitoring is not there, we can see a tachycardia, tachyarrhythmia, unexplained. Other than that, a rise in temperature is a later sign. Sometimes early rapid rise in temperature can be seen, which rises over a period of minutes. And the late presentation can be rhabdomyolysis, which resulting in the acute kidney disease and can lead to a multi-organ failure, electrolyte disturbances, also lead to a DIC presentation, cardiac failure, cerebral edema, coma, and death. The differential diagnosis, we can go for a sepsis, thyroid storm, neuroleptic malignant syndrome. It can be a heat stroke or anaphylaxis. Sometimes underdosing of the succinylcholine also can present with the messenger. So treatment, we can divide into immediate management and management. Immediate management, here we need to halt the process as soon as possible. So what we do is initially we need to remove the triggers, like discontinue all the wall, no further succinyl choline doses. If you are on halfway, a high fresh gas flow should be given, preferably 100% oxygen. We need to flush the circuit. Ideally, it is better to replace the breathing circuit and the soda lamp. We need to switch over the maintenance to the IV injection drugs. Coming to muscle relaxation, dandelion sodium has an inhibitory effect on the rhinodine receptors on the sarcoplasmic reticulum, which inhibit the calcium release. So it can be inconstituted with a dose of 2 to 3 milligram per kg initially, followed by a 1 milligram per kg bonuses up to every 10 minutes as needed for the relaxation. The reconstitution of dandelion sodium is a bit time consuming also. Then we also we have to cool the patient, like we can use a cold IV fluids, ice packs in the axilla and groin regions, cold bladder irrigation, and the cold water installation through the rice tube can be given. We need to look for the hypoxia and astosis also should correct, like hyperventilating with 100% oxygen. We also can give a soda bicarb to treat the acidosis and enhance this also can enhance the post alkaline diuresis. We need to repeat the artificial blood gas analysis every 6 hours for next 36 hours. Then rhabdomyolysis can also occur. So to prevent this, we can go for a hydration. Urine output should be more than 3 ml per kg per hour. And we need to alkalize the urine also. This can reduce the renal failure. Then we need to treat the hyperkalemia. This hyperkalemia itself can contribute to the arrhythmias. For hyperkalemia, we can go for insulin. Insulin like 15 units and 100 ml of 20% glucose, which is given over 60 minutes, or a bicarb boluses. Salbutamol nebulizers can be given, or we can go for a calcium, 10% calcium gluconate IV injection over 10 minutes can be given. In refractory hyperkalemias, we also can go for a hemodialysis. K-bind sachets can also be used, but it is slow acting. For the arrhythmias, if and so it occurs, we can go for a max of 2 gram IV or 10 minutes or amiodarone infusion boluses 5 milligram per kg followed by infusion doses. These are all the immediate management. In the ICU management, we need to continue all those above treatment, and we need to maintain a continuous monitoring. We also should look for the AKI presentations and compartment syndrome and DIC presentations. Further, we need to refer this patient to a specialty center for malignant hyperthermia testing. There is also a grading called Larach clinical grading scale, where they score the patients according to the muscle rigidity, myonecrosis, respiratory acidosis, temperature, and cardiac involvement. With total score of more than 50, shows a certain of malignant hyperthermia presentation. And we also can go for arranging the malignant hyperthermia trolley, where we restock drugs on the regular basis also. This trolley can contain dandelion sodium, sterile water, soda bicarb, injections, glucose and insulin, calcium chloride, mannitol, temperature probes, and a flowchart or a diagram printed for the references. So once we know these patients are susceptible, when for giving the anesthesia for giving anesthesia for malignant hyperthermia patients who are susceptible, likely, we can go for alternate techniques like lesionals or blocks, or we can use IV induction agents for the maintenance. And we need to prefer them as a first case in the OT. And we need to keep the circuits, all the breathing circuits as a new breathing circuits. We need to flush them with the high fresh gas flow, like 10 liter per minute, at least for 20 to 30 minutes. We need to be mindful about avoiding the triggers of malignant hyperthermia, and we need to keep the resuscitation drugs always ready, and the senior presence is always required.
Very
Sodium.
Go ahead.
So dandelion sodium is a phenyl hydantoin derivative. The formulation will be a lyophilized orange powder, which is reconstituted with water, produces a pH of 9.5. So this powder has 20 milligram of dandelion sodium, 3 milligram of mannitol, which is added for solubility, and it also has a sodium hydroxide. This should be reconstituted with a 60 ml of a sterile water, which is given along with them. So this reconstituted dandelion should be used only within 6 hours. And it after reconstitution, it should be stored under 15 to 25-degree temperature itself. The main mechanism is it depresses the excitation contraction coupling in the skeletal muscle and reduces the calcium concentrations intracellularly by binding to the ryanodine receptor. Uh, Other than that, metabolism is by liver and excreted in urine as a hydroxy metabolites. Distribution is 80 to 90%. It is albumin bound. And coming to elimination, it stays in body like 3 to 11 hours in adults, 20 hours for the children. Pharmacodynamics, it also has an antiarrhythmic effects and it improves the beta adrenergic responsiveness in case of failing myocardium also, and also has a GABAergic effect. So mild sedation may occur. Metabolic effect, it reduces the force of electrically induced muscle twitches, but it has no effect on the action potentials. So it also can be used in the neuromalignant syndrome, spasticity or ecstasy intoxications. And the dosage for malignant hyperthermia, as I told, 2.5 milligram per kg bolus once symptoms recognized, and followed by a bolus of 1 milligram per kg. Maximum up to 10 milligram per kg can be given. After successful treatment, we need to give a bolus dose of 1 milligram per kg every 6 hours for next 24 hours. It is a bit irritant, and we need to give it on a large bore IV cannula. That's all.
Very good. That was a very excellent exhaustive presentation. And only thing, family history in a non-muscle disorder patient. You mentioned about Duchenne's dystrophy, Becker syndrome, and other things. The non-syndromic patient also, family history of any siblings or relative dying of some complication that should be elicited. And if it is positive, then it is better to do a
Muscle
which
biopsy.
test will caffeine halathane test before taking up the patient. Okay, that is the only point that I think I can add to this. Otherwise, very good preparation, all very detailed method. So once the diagnosis is made, sometimes you can identify the condition at the very induction stage itself. If you are using scoline and you don't get adequate relaxation to introduce your laryngoscope with a mesenteric spasm, that time itself it should trigger you. I mean, it should give you a clue that the patient is likely to develop malignant hyperthermia. Okay, so that is the earliest indication. Mesenteric spasm after scoline administration is the earliest indication of a likelihood of malignant hyperthermia occurring in the patient. And intraoperatively, within about 15 to 20 minutes or 30 minutes of surgery, once the volatile has been switched on, even if you don't have any mesenteric spasm, you are able to intubate well. And then once you switch on the volatile anesthetic agent, especially halathane, sevoflurane, or isoflurane, then the patient starts having abrupt rise of CO2. VTCO2 levels suddenly go up even before the temperature starts increasing. So that is another indicator that you have to think of, that the patient is likely to go in for malignant hyperthermia. And then only the patient starts increasing temperature. And you will find normally, unless you have a temperature probe, you will be missing this at this intraoperative monitoring. And the only way to find is under the drapes, you will find the patient will be sweating. The limbs will be perspiring so much that the drape itself will get wet. Or patient, I have seen only one case I have seen where sweat has been pouring like as though a discontinued drip has been flowing somewhere. That much of perspiration happens. So you have to be very careful and alert the surgeon to stop the surgery. And dantrolene is the most definitive treatment. And, of course, nowadays awareness is being created. And because it is not a very common condition, storing dantrolene, which is quite expensive, becomes not a practical solution because all hospitals will say the shelf life is about only 1.5 years or 2 years maximum. And if you are not using it, you have to discard, then that costs quite a bit for the hospital. So many hospitals do not wish to store this. That is the only drawback with this particular treatment. But that is a very rewarding treatment because earlier, if a patient undergoes malignant hyperthermia, mortality was 95% before dantrolene. But once dantrolene has come to market and you have started using it, mortality is reduced to 10%. So there's a gross improvement in the results. So you must try to get the dantrolene and try to save the patient as much as possible. I'll just share the